pharmacists are indispensable. We really are. You as public health leaders have an opportunity here to do something significant, something really of a national scope. So I encourage you to keep that in mind. We really have a lot of things that we can do. I know we're going to be focusing on antivirals, but be thinking about what else this could potentially apply to in the future. Don't close anything out. Don't make it so restrictive that anytime something changes, you have to change regulation. Really keep it open, and that's a lesson I've learned over my career with just doing policy and regulation through the federal level. We really want to do that. So having experience within a closed system with whooping cough and anthrax being deployed with the Public Health Service Commission Corps, tuberculosis outbreaks and different things like that, it really does take the team to come together to deal with those issues. Collaborative practice agreements. We have significant experience with that in the federal sector. Obviously we don't have to abide by the state practice acts, so some see that as a significant advantage in being able to move forward with that. But I think we can at least offer processes that could be incorporated into the state level. One thing that we learned is when you have a collaborative practice act, to keep it open and flexible. And one thing that we've done, and we work with the Indian Health Service and the National Clinical Pharmacy Specialist Credentialing Program, that is now open to all the public health service officers, regardless of what agency they're in, and we hope to open it up to DOD and VA eventually as well. Having an open collaborative practice agreement that's not doesn't have a strict protocol embedded in it. You simply have a collaborative practice agreement, and then the physician says pharmacist X is able to dispense, prescribe modified treatment or end treatment, or do CLIA wave testing according to this specific clinical practice guideline. That way, if the evidence changes, you have a clinical practice guideline that's automatically updated, and you don't have to update your collaborative practice agreement, because it becomes an administrative burden when you do that. So those are some of the things to try to keep in mind. The challenges of addressing across all states, they're significant. I know there's lots of moving parts and pieces when you get to the state level. We did at this pharmacy summit, one of the actionable items that came out of that was for a work group out of that to be formed to look at and work with NABP to adjust their Model Practice Act to incorporate some of the standard verbiage that we would all like to see in the state practice acts, because that's where folks go to do that. And I know some states have taken the lead and already modifying. I think Minnesota is one of them. I know Washington State has done significant things with the things that they do. But it might be good to remember that, so if this work group does come to fruition, that we can put a public health piece in there as well. That would be part of that Model Practice Act. The framework, the regulatory framework, and I work with a lot of lawyers, so I often say I'm not a lawyer, but I play one in the Bureau of Prisons, just because we interact with them so much. But keep it flexible. Keep the regulation so that it can be expansive and transcendent across all public health emergencies, and leverage what's there. There's a lot of examples of successes, what the MRC has done and what they continue to do, or what they could do. Really look at those lessons learned and see how we can create a toolkit or a toolbox for people to go to look at that. Minnesota has had expansive revisions, and I was talking to Greg a little bit ago about the training program that they have for CLIA wave testing. I think it's absolutely wonderful, and I think there really is a big role for that in emergency preparedness. So the challenge to you is to, and I learned this at there's a federal health futures group, and I know Captain Casado was there as well, and one of the things that they say up front is when somebody says something, you say yes and add to it. Don't say yes but. So stay aspirational in that, and that will keep you moving forward. Don't look at the limitations, look at what could be by saying yes and. And I find that students are much better at doing that than some of us with more experience. So I challenge you to look at this as the beginning, not the culmination of what's going to occur. This is only the beginning. We have a lot of work that we could potentially do and expand to other areas. Look at potential interactions with Office of National Coordinator for the medical record. How would that play into the surveillance type system with connecting all the pharmacies and the public health systems together? How can you work with big data to do that surveillance type thing when you start plugging in the pharmacies? I know NIH has a current thing that they're doing with big data and HIV data so that they can do epidemiological research on that data. They have a meeting in a couple weeks, and I learned through that because of the Office of National AIDS policy work group that I'm on. So there's a lot of things going on there, and the Office of National Coordinator can help maybe connect some of the dots with the electronic health record and how that plays in the local community pharmacies. So I challenge you as a pharmacist and as a public health professional and as a participant in our public health system to really do something significant. And I would be remiss if I didn't say something about smoking. I know if Admiral Luzhniak found out that I didn't put this slide up there, he'd probably get mad at me, and he could probably attest to that. So I just wanted to say and give a shout out to APHA regarding the report that was just released by Acting Surgeon General Boris Luzhniak, the health consequences of smoking, 50 years of progress. And it was launched on the anniversary of the landmark study, or landmark report in 1964 on smoking and health by then Surgeon General Luther Terry. And it fits into pharmacy because Admiral Scott Giberson, a pharmacist and the Acting Deputy Surgeon General, did a call to action for pharmacists on smoking and the consequences and how we can get involved. So if you haven't seen that, please do. I have the link there. You can't hardly read it, but I know APHA has it listed on their website, and so I encourage you to go there. And it's just another important piece of how pharmacy and public health are inextricably linked. So with that, thank you for having me, and have a good day.
Thank you so much. We're really pleased that you're here. Any questions? Okay, well, we will move on in our slides, and so I will take a few minutes of your time, and those of you who are not aware of our Flu on Call project, as Andy said, we were calling this our nurse triage line project, and have now achieved a good consensus on this name for this project. I want to give you a little background to help inform the discussions that we're going to have today about collaborative practice agreements. So one can envision during a severe pandemic that if a lot of people become ill all at the same time, how crowded emergency departments, clinics, medical offices would be. The phone would be ringing off the hook. And some of you can actually close your eyes and see that happening during 2009 H1N1. If that does happen in a future pandemic, there would be delays in seeing a provider and delays in treatment. And all of us know that unlike other countermeasures, antivirals are prescription medicine, and you have to interface with the provider to get access to the medicine. So the potential solutions we started working on a couple of years ago, we really looked back at 2009 H1N1. We're inspired by Minnesota's experience, and you're going to hear from Dr. DeVries in a few minutes about that experience. But we also know there's a finite ability for the healthcare system to stretch or to ramp up and increase supply of services. So we really need to be thinking about how can we meaningfully reduce demand for face-to-face care and ultimately right-size the level of need from a person with the level of care that they'll receive, and looking at all facilities and all providers and doing so. We need to also think about leveraging the evolving notion that healthcare is becoming multidisciplinary. This is where nurse practitioners like myself and pharmacists come into play as key providers of care, and multi-site. And there's an increased role of telephone triage and care, as well as telemedicine in the country today. So all of these things lead us to some potential solutions. So the Flu On Call project was started in 2011, and the primary goals of the project were to improve access to antiviral medicines during the pandemic, to provide an alternative to face-to-face provider encounters, and to hopefully reduce medical surge and increase the appropriate use of medical resources. We started to look at what exists today, and it was already mentioned by one of our participants, that it's important to leverage things that work well every day. And if you look on the right side of this wheel, health plans, hospitals, providers, clinics, and others operate nurse triage lines every single day, and we would guess that at least 100 million of Americans have access to that service. I know in Atlanta that if you call your pediatrician's office at 501, you're not talking to that office, you're talking to a bank of nurses at the hospital down the street from CDC, and they're operating a triage line. We also know that a number of local and state public health departments have plans to open up an emergency nurse triage line during an event, but we don't believe that everyone will have access, even with that availability. So we started to say, what exists today that might be able to serve as sort of a pop-up or a just-in-time emergency triage line? And it became very apparent that poison control centers would be an extremely important resource to think about, as well as 211 information lines. What you'll learn from what Dr. DeVries is going to share with us is that their triage line experience in Minnesota, about 34% of the callers only needed information. So we felt it would be important in developing a triage line resource to make sure that there was a way at the beginning of a call that a person could be screened to see do they need information or do they need medical triage, and save the clinicians, which are a scarce resource, for the clinical care. So let me explain a little bit more. First of all, 211 information lines. There are 241 of these call centers all over the country. They currently cover about 91% of the population, and the specialists who answer the phone provide social services information. They provide emergency response information during Hurricane Sandy, for example. They worked with public health and gave out a lot of information. They help people who need to access resources. They may be calling, where can I get a flu shot? How do I enroll in Medicaid? Where do I get food stamps? A whole host of social services. And so this is an established entity that is sponsored by United Way. And also, there are 311 lines in the U.S. as well, but they are not connected by a national organization like United Way 211. But there's a number of information lines that work every day all over the country serving the public. Yes?
Are those available 24 hours, or what's the time?
Some of them are available 24 hours. Most of them go offline about 10 o'clock at night, but they have the ability to ramp up 24/7 during an emergency.
So, looking at the bottom, do I see it's only defined as access with landline telephones? Is there any information as far as those that would have access with mobile phones?
They're really transforming themselves right now.
Okay.
Yeah, this is an imperative. Any telephone service has got to be able to integrate the mobile line. I mean, none of my kids have a landline. They're like, what's that? So, I mean, I think, we're all moving away from those landlines, and their services moving in that direction. The other entity that we've identified, and you're going to hear from Dr. Bueller more, is we met colleagues from the American Association of Poison Control Centers, and they educated us about the vast capabilities of poison centers. There are 55 poison centers in the U.S. Although they aren't located in every state. Every state is served by a poison center. They're staffed by registered nurses and pharmacists. They operate 24/7, 365. And these clinicians are experts at providing triage, medical advice, coaching, counseling, and information over the telephone. And you'll hear more about that from Dr. Bueller. So we started to think, how can we put the pieces together? If a country is struggling under a severe pandemic or other public health emergency, people can't see their usual providers, what could we put together to help improve their access to antivirals? For those of you who are not clinicians, it's really important to get an antiviral in someone, preferably within 48 hours after symptoms arise. And you know how long it takes people to finally decide to reach out for care. Probably most of that time is already gone by the time they reach out. So further delays are only going to impede treatment, and there is a very strong relationship between timing of treatment and its effectiveness. We spent a good bit of time looking at the acceptability of this idea. We pulled together some core partners, ASTO and NACHO, a number of others around the table, and started working on this a couple of years ago. We were invited to provide a concept paper in the Biosecurity Journal. You have a copy of that on your thumb drive. We've had multiple discussions with public health and emergency management partners. And Flu on Call, this concept was approved by CDC leadership last year to incorporate in our CDC pandemic flu response plan. We also did a partnership with the Institute of Medicine and did 3 public engagements in 3 communities. And I wanted to share some of the snapshot results with you because I think it really is relevant. We asked a question of the public in Fort Benton, Montana, which is really rural Montana, Chattanooga, Tennessee, and inner city LA. And one of the questions were asked to the folks that attended, and they were just regular folks in the community. They weren't experts or professionals. They were just sort of a selection of folks in the community. We asked them, would you trust a nurse triage line nurse to determine if you need an antiviral prescription over the phone? And you can see by the blue bars, the dark blue is strongly agree, and the light blue is agree, that the preponderance of participants, and there were over 200 folks, agreed that they would trust a nurse to determine if they needed an antiviral. And look at the next question. Would you trust a pharmacist working under a collaborative practice agreement with a physician to prescribe and provide an antiviral drug? And the results are even stronger than that for nurses. Very strong concurrence. Now, I want to say that in Los Angeles, we found, no matter what the question was asked, a lot more reluctance, a lot more uncertainty about trusting systems. Some of the people in this community responded they have felt really left out of some of the medical care that was provided in the community. But when we started talking to them about pharmacists, there was a very strong connection with pharmacists and a very high trust level. And this really helps me think about hard-to-reach communities, underserved populations, and the role that pharmacies and pharmacists can take in reaching those populations. So we also looked at the feasibility of Flu on Call. We held a simulation exercise a couple of years ago in El Paso, Texas, where we actually had actors at CDC with scripts call a 1-800 number, and 211 operators and poison center specialists answered the phone as if it was real and gave their advice and triage to the person. And then we compared what we thought the disposition of that call should be with what actually happened, and there was a very high correlation. Also, the actors were asked to fill out an evaluation after each call about whether their needs were met, and 95% of the callers said their needs were met. We're working with Jamie Ware and doing a legal review of 50 states' Nurse Practice Act, and we really want to explore the use of collaborative practice agreements for pharmacists for this effort too. And that's one of the reasons why we assembled you today, is to think through some of these things. We funded some new activities with the American Association of Poison Control Centers and United Way 211 to identify some pilot sites this year to work on for surge readiness. And we continue to work with our public health partners and pharmacy partners in this work as well.
Lisa,
Yes.
was the scheme to have it set up as a tiered call system, where it would initially go to 211, and if they were screened as only requiring information, general information, the call stopped there, or if it was they needed clinical information, they were referred or forwarded to the Poison Control Center?
Perfect question, and here's the answer on the slide. That was couldn't do better on time. I think I have to buy his lunch now.
It'll be $5.
So this is how we believe it will work. The caller will dial a specific toll-free number, not the usual 222 number that poison centers use every day. We do not want the public to become confused with the important poison control center number that's on every parent's refrigerator, we hope. That's sure it should be, right? But there will be a specific toll-free number. I think we've actually snagged flu call as a number for right now. But the caller would listen to a very, very short message, ask them to enter their zip code to aid with call routing, and then they would go to a 211 specialist. Now, we also are reserving an ability during a big surge of calls to allow the caller to listen to some pre-recorded messages if that would suit their needs, but they can bypass that. The specialist would immediately ascertain if they're ill or caring for someone who's ill, and just like you said, if they just need information, they would be given that information. If not, they might be asked another question, which is, are you a member of a participating health plan or system? The Veterans Administration would like us to send their people back to them, and we're also talking with some of the large national health plans that do have triage lines about sending their folks back to them as well. And then otherwise, if they aren't going to be sent on or transferred, 211 specialists would transfer the call to the poison center. And that is the framework we use in the simulation exercise, and that is the framework that we're going to use going forward with drills and exercises. So our assumptions for planning for this project is it would be a nationwide availability of services, that we believe that some callers can be best served by where they belong. If they're already a VA beneficiary or belong somewhere else, they might be best served there. And we are also doing some work with ASTO and NACHO to see about states and what their plans are to stand up triage lines during a pandemic. But I just came from Albuquerque, New Mexico, where they have a program called Nurse Advice New Mexico that runs every single day. And anyone who in New Mexico can call and get triaged over that phone line. They primarily serve the Medicaid managed care plans, some of the commercial plans there, and some after-hours doctor's offices, especially in the rural areas. So New Mexico may want us to send all their callers back to them. We believe that this system only should be used in a severe pandemic, or I would say severe emergency, when a large proportion of people are seeking care and where medical systems are not meeting the need. This system should not come in to interfere with anything that's already working.
So the question on supporting this model is the assumption that this is all being paid for by the government.
Yes.
So the plans, you don't have to worry about the plans covering for the prescribing.
The assumption is that the surge staffing would be financed by our efforts, and that, are you talking about the cost of the antivirals?
Well, there's two parts. There's the evaluation, triage, and ordering, and then there's the filling of the prescription.
Right, and we are still working on the latter part, which is the filling of the prescription, working with HHS on their EPAP program as a possibility for helping people who are uninsured or underinsured. So there's still a number of things in the works that might be very helpful for that.
So, under what circumstances would this system kick in? Is it a declaration of a national emergency?
Yes.
So if something like Katrina, this would not kick in, or regional
We
way,
would probably, at this point, need to respond to the request of the region that's affected. So let's say there was an anthrax attack rather than a natural emergency. Think about more like a public health, threat, like a bioattack. The area may need that assistance. They may ask CDC to do that. But for less than a regional event, and then using the pandemic scenario, we would only use it for a widespread, severe pandemic after a declaration has been determined by the Secretary.
Thank you.
Yeah, that answered part of my question in terms of the definition of a severe pandemic, given the lessons learned from H1N1, which was considered a modest pandemic.
That's right.
But pandemics generally result in large proportions of people experiencing illness. Is that defined in some clinical realm of severity of illness? And then also medical system surge. How is healthcare capacity surge defined by BCC?
Yeah, we're working on that right now.
Okay,
We
so
really
these are
don't
real
have-
broad
This
assumptions.
is broad right
Yeah,
now, and
okay.
I'm not certain that we'll ever get the triggers down to I mean, we'll certainly have criteria, but I would, I still believe the ASPR or the secretary could call CDC and say, we need this, please, let's implement it. So, the leadership discretion will be a part of this as well, as it should. We believe that the provision of antiviral prescriptions might be best facilitated between providers and nurses if they have a standing order framework or some sort of framework. Ideally, that collaborative practice agreement or those standing orders would flow from the state's response down to the providers who are working with the public to do this. That might afford the best coordination and also protection for those entities who are delivering this care. And we're working on how to link, and one of the conversations we're going to have today during emergencies is who signs the CPA? And how to connect that to the official response efforts. We also believe this could be useful for other public health emergencies, as you said. And we also believe that it would work best if the network is built, tested, and confirmed, ready to activate. So I don't want to read you this, but we believe there's a number of benefits to having a coordinated triage line during an emergency. What I really want to talk to you about are some of these key questions, and that is, how could CPAs be used to allow pharmacists working in poison centers to provide access to antivirals? Dr. Buehler is going to speak next about some ideas for that, but also we really want to hear your discussion about this as well today. And also, in addition to this very specific project, how can CPAs be used by community pharmacists to enhance the availability of antivirals generally? And what steps can we take now to improve the possibilities of using CPAs during a future public health emergency? Knowing that we have a tool in the toolbox, what can we do now to enable it to be activated when we need it? So I appreciate your time on this. Do we want to take questions or keep moving?
You can take some questions if you'd like.
Yeah,
You get 2 more slides though.
I know, but I was trying to be cognizant of the time.
So is there, or do you anticipate a national contract with 211? And if so, would there be some sort of formalized training that's uniform across all states, or how would that work?
Yes, so we're working with APCC, American Association of Poison Control Centers, and United Way 211 at the national level, where they have identified each 10 pilot sites this year to work together. They're going to be doing standardized training and communications with their entities. And we're going to be learning together about what it might take to surge and stand up a response. He reminded me that it's very important to recognize the core project partners on this effort have been critical and essential to moving forward. And about 40 additional partners on this project. It has really been a partnership effort, like you noted, Graham Robina, about how important these partnerships are in doing this kind of work. Other questions?
I have one. In reading the material last night, it was evident that this, it appears that this is on treatment, but is there a prophylaxis?
Right now, we're not, we haven't inserted a prophy piece to this because with the amount of antivirals available, we don't believe there would be a widespread protocol for prophy other than post-exposure prophylaxis. And that has not been developed enough to insert in this protocol. So we're just going to keep this in treatment.
Okay, yeah, I should have been more clear. I meant the post-exposure
Yeah.
prophylaxis. So that's
Yes.
included. Okay.
All right, well, let me turn the slides and the discussion over to Dr. Buehler. Is it, I believe your next one is, okay, I'll be happy to.
If I'm, stay on next, then?
You're next.